Hey there, my name is Glenn Adams, and my master's project is on unstable angina pectoris. Throughout this presentation, I will just be referring to it as unstable angina. In this presentation, we're going to talk about the pathophysiology, signs and symptoms, the clinical assessment, diagnosis, and treatment of unstable angina. The pathophysiology of unstable angina falls into a category of diseases called acute coronary syndromes. I like to think of this as an umbrella with three diseases in it, which are ST elevation myocardial infarction, non-ST elevation myocardial infarction, and unstable angina. So all of these diseases are under the same umbrella because they share the pathophysiology that oxygen supply and demand to the heart are imbalanced. Unstable angina specifically differentiates from the other two because the oxygen demand is stable to the heart, but the oxygen flow is decreased. This brings me to my next point that unstable angina is typically caused by atherosclerosis of heart vessels or plaque buildup in the vessels. With that being said, the risk factors with unstable angina and coronary artery disease are very similar, being smoking, male sex, diet, sedentary lifestyle. Signs and symptoms of unstable angina. Typically, patients can present with worsening chest pain than what they're used to, chest pain at rest, or increase in frequency, duration, or intensity of chest pain. Some patients have all of these symptoms, some patients just might have one. For the clinical assessment, first thing you're going to look at, we're going to talk about it, are the signs and symptoms. For unstable angina, when you're suspicious of this in a patient, one of the first things you're going to do is get an EKG, ideally within 10 minutes of presentation. You're also going to check out their vital signs and physical exam. We'll talk more in depth about EKGs in the next slide, but for physical exam findings, it's mostly used as a tool to rule out other potential causes of chest pain. For example, if a patient presents with chest pain that's more due to a musculoskeletal origin, such as costochondritis, they would have chest pain that's reproducible with palpation. Other physical exam findings that may be discovered on exam and are indicative of unstable angina could be a paradoxal splitting of the S2 or S4 heart sounds and a new mitral regurgitation murmur. It's important to note that unstable angina and NSTEMIs present very similar clinically, and you have to get cardiac biomarkers to differentiate one from the other. For the diagnosis of unstable angina, you can use an EKG. If the EKG is indicative of a STEMI, then the ST segment will be elevated. If it's an NSTEMI, there might be ST depression or T-wave inversion. And then with unstable angina, your EKG could be normal or in between attacks of the patient's chest pain, or it might have inverted T waves showing previous ischemia. The big diagnostic finding with unstable angina is that when you get cardiac biomarkers, they will be within normal limits, whereas with an NSTEMI, they will be elevated. The gold standard to diagnose unstable angina is angiography, but is not always necessary. It may be clinically appropriate if, as a provider, you're considering revascularization. Treatment for unstable angina, like most diseases that we see in practice, start with lifestyle modifications. So you can't overstress a clean diet and physical activity. The pharmacological side of treatment is going to be two separate categories, one of them being medications that have proven reductions in mortality, and the other classification being medications that have no proven mortality benefits but help quality of life and symptom management. For the medicines that are proven to reduce mortality in patients with unstable angina, this is going to be antiplatelet therapy. So your patients will be on aspirin and or clopidogrel. They'll be on a cardioselective beta blocker, so metoprolol. And then they will be on an ACE inhibitor like lisinopril and also a statin. Meds that aren't going to reduce mortality but make the patient feel better or increase their quality of life would be non-DHP calcium channel blockers, so either verapamil or diltiazem, and then nitroglycerin for symptomatic relief. Ultimately, the biggest cure for unstable angina, if indicated, would be revascularization through PCI or CABG. These are the references I used to find the most up-to-date advancements in the literature. I hope that you enjoyed this presentation on unstable angina, in which we covered the pathophysiology of the disease, signs and symptoms, clinical assessment, the diagnosis of unstable angina, and treatment. I hope this helps out in your boards and on our upcoming test. Thanks for listening.